Welcome everyone to today's webinar. Today we'll be updating you about Parkinson's disease and cannabis with Dr. Tiago Mestre. Today's session is being recorded for future viewing. You will be able to access the recording on the Parkinson YouTube channel. To report any technical issues at any time during the webinar, please go to the panel at the right of your screen. To open and close this panel, click on the red tab and you'll see a chat icon. Use the To Admin and Ask a Question buttons to type in and submit your request. Dr. Mestre is a movement disorder neurologist. He completed a clinical research fellowship with Professor Anthony Lang at the University of Toronto from 2010 to 2013. He is also an associate professor at the University of Ottawa and an associate scientist at the Ottawa Hospital Research Institute. Additionally, he is the director of the Deep Brain Stimulation Program at the Ottawa Hospital. His primary research interests are therapeutic development, including conduction of clinical trials for unmet care needs, care integration in Parkinson's disease with the Integrated Parkinson Care Network, and study of placebos. Currently, he is co-chair of the Task Force on PD Subtypes of the International Parkinson and Movement Disorder Society and chair of the Education Committee for the Movement Disorder Society Pan-American Section, MDS-PAS. He received funding from Parkinsons Canada for a clinical trial of cannabis for pain in Parkinson's disease together with Dr. Susan Fox. Please feel free to add into the chat any questions you have as they come to mind during the presentation. We will make every attempt to answer all questions after the presentation. And with that, let's welcome Dr. Mestre.
Good afternoon, everyone. First, I would like to thank Parkinsons Canada for this kind invitation and hopefully use these awkward times, unprecedented times, to bring more education about Parkinson's disease and ongoing research that's being conducted. And I think definitely the topic of cannabis, it's in many minds of patients with Parkinson's disease. I see it in my practice. We see it in society, in newspapers, in the Parkinsons Canada. And so today I'll try to bring you the rationale for researching about the therapeutic use of cannabis, then really go over some of the data that shows how people with Parkinson's disease are interested in how actually they've been using it, and then focus more on pain, which is my research interest in cannabis and Parkinson's disease, and then briefly mention the clinical trial that was funded by Parkinsons Canada on cannabis oil for pain in Parkinson's disease. And so, the history behind the use of this plant called cannabis sativa is long. We know that this plant has a huge number of pharmacological active compounds that potentially could have a therapeutic application. Most likely, many of you have heard of these two compounds. So THC, or tetrahydrocannabinol, and CBD, or cannabidiol. The major difference between one and the other in terms of its therapeutic application and action is that THC it's a more psychotropic cannabinoid, so potentially could lead into issues with safety and tolerability from a brain perspective, potentially causing confusion, hallucinations. And less likely the cannabidiol, the non-psychoactive cannabinoid, and actually has sedating, anti-emetic, and analgesic properties. One important distinction is what is an approved therapeutic product and what is something for potential medical use. So for a compound or a medication treatment to be potentially approved for a therapeutic product, for a therapeutic use, it requires a consistent development with clinical trials conducted and ultimately being approved by Health Canada for that purpose, which basically looks at the evidence, how efficacious is it for a specific treatment of a specific symptom, but also about the safety. So currently what I have to say, although as we know in Canada, it's been legalized both the recreational and medical use of cannabis is that it's not approved as a therapeutic product. And I'm going to try to show you why. But first, look at what has been already approved by Health Canada. So mostly we're looking at synthetic compounds, so substances that were created in the laboratory, and they mimic the actions of the natural occurring cannabinoids. And so there's a precedent for the use of these compounds in medicine. So these are just some examples that you can see. So Nebulone has been approved for severe nausea associated with chemotherapy. Dronabinol, which is related with THC, has been approved for anorexia associated with weight loss or nausea associated with chemotherapy also. And then another compound called Setivax has been used in multiple sclerosis and approved for the treatment of increased tone in patients with multiple sclerosis. So far, no compound has been approved for Parkinson's disease, regardless of the symptom. What is the other reason why we should consider cannabinoids for treatment, either in Parkinson's disease or in other conditions? So we do have a system in the brain that responds to the action of these compounds. And so we have these receptors called cannabinoid 1 and cannabinoid 2 receptor. And also on top of that, it's a system that is used by natural occurring substances in our bodies and in our brain called endocannabinoids. And these are two examples of these substances. And then we also have, just for completeness, so we have another type of receptors. So these are small molecules that are in the membrane of cells, so including also nerve cells, and they allow for these substances to interact with the cells, with the neurons, and then have some action that could, as I mentioned before, could explain the use of cannabis for pain and, for example, for nausea, and also for lack of appetite. So in a way, this gives the basis for, yes, there's a system that it's naturally available in our bodies and in our brains. So the main question remains, how efficacious is it for a specific symptom, but also the safety of using it, which relates with the type of compound we're using, but also the dose that we're using. And so those are important questions that we always need to address when trying to see the benefits of a given substance in the treatment of any condition, including Parkinson's disease. And through live neuroimaging studies, so these are called PET image, where basically a compound that is radioactive is administered to a person, and we know that the compound is going to bind to one of those receptors, in this case the CB1, and so what you see, it flares up the brain. So that's what it and tells you that these compounds exist in the brain and they're active. And also, I don't know if you can see my pointer, the star, but one important aspect, you see there's this red, almost coma-shaped binding. So it's red, so that means high intensity of binding. It's actually the basal ganglia, which are structures deep located in the brain that are related with movement disorders and obviously with Parkinson's disease. So again, a connection and a rationale based in this data that potentially cannabis or cannabinoids can have an action in the brain and these structures that are somehow affected by Parkinson's disease. And then ultimately, we know by studies and by history that endocannabinoids have been studied that they have a major role in pain control. As I mentioned, they can also have for food intake against nausea, but also things such as temperature regulation and perhaps things that are more related with Parkinson's disease. So things such as cognition or motor coordination. So what are the news or the information about the use of cannabis in the life of people with Parkinson's disease. So this is just a sample, I have to say. Likely you'll find more things, but I looked mainly at papers published in peer-reviewed journals. And so this one was by my colleagues in Israel. So they looked at try to include and interview people with Parkinson's disease that had used medical cannabis. So either in the smoked version or on the oil formulation. And I hope you can see the fine print in the table, but basically what you see for the ones that might have some difficulties is that, so you have a wide range of symptoms, both from the slowness of the Parkinson's, the tremor of the Parkinson's, but things that we call non-motor symptoms such as pain, mood, insomnia, nausea. You can see that in the vast majority, there was a benefit and an impact, a positive impact reported by patients. One thing that I have to emphasize is that although the authors go on mentioning that medical cannabis did not cause major adverse effects, we do see in the table on your right that there was a significant proportion of patients that experience psychotropic adverse effects. This could be confusion, hallucinations, among others. And some also had any physical adverse effects. Okay, so then I think it's an important idea that I'd like to convey today. So if we go from this data, depart from this data, we can see that patients report a benefit, there are potential side effects. So ultimately, how do we tease apart what are specific effects of cannabis? What are things such as, for example, the expected benefit someone legitimately might have, and we know that then can reflect in the own experience of taking a given medication, and that has been, for example, expressed in the placebo effect, which is also one of my topic of interest. So how do we go from this data to something that it's more structured and provides more rigorous evaluation of a treatment? And this is very important because currently, as you know, it's available in our society. There's clinics dedicated to the use of cannabis, but we need to be more rigorous and try to really tease apart what is the actual benefit of these compounds or other compounds, and what's the safety. Otherwise, we'll be in a realm of poor science and, in a way, poor medicine. And so there's a path that needs to be trailed. And this is an example of how things can go wrong. So this is from my colleagues in Toronto Western Hospital. So as you see, Dr. Fox is one of the co-authors, also Dr. Lang. So it was really a call for the possible hazards use or hazard repercussions of cannabis in Parkinson's disease. So briefly, this is a 70-year-old lady with 12 years of Parkinson's disease. She went on having Nabilon, which is a synthetic cannabinoid formulation for dystonia of her foot, and she had already some visual hallucinations, and not significant cognitive impairment, but went on having more severe hallucinations, quietly entering in panic attacks and paranoia. That, and I think this is important to emphasize, was persisted even after stopping the Nabilon and required admission in hospital. And so likely what we see here is the conjunction of someone having Parkinson's disease, already having some frailty in terms of her cognition. She's already on a complex cocktail of medication that we know by itself can trigger or can predispose people to confusion, hallucinations. And on top of that, in this case, Nabilon was the final trigger, but things persisted even after stopping Nabilon. So again, safety, it's definitely one of our main concerns as physicians dedicated to Parkinson's disease and also as researchers. Another interesting study I would like to show you just to illustrate first how this is a reality. So it is being used in society, and I would say sometimes by physicians. And so this was a survey done to centers of excellence in North America dedicated to Parkinson's disease. And so this was interviews to colleagues of mine. And so you see that in blue, for the different columns that respond to different symptoms, blue means good, so means improvement after the use of medical or medicinal cannabis. And really you see that the symptoms that I mentioned to you, so appetite, pain, nausea, are the ones that seem to have more rewarding benefit in terms of the physician report. I have to acknowledge that things such as tremor, stiffness were kind of 50-50 in terms of, although improvement versus no effect. So again, it gives us an idea that potentially this could be explored in the future. The same for dyskinesias, although as you'll see, there are studies done for dyskinesias that didn't render consistent positive effects. But then you see other things that are of concern. So hallucinations, memory problems, balance, sleepiness, motivation, and fatigue. They seem to, according to these physicians in centers of excellence in North America, they seem to associate the use of medicinal cannabis with worsening. Okay. So again, there's equipoise to consider why shouldn't we use cannabis in Parkinson's disease, but also can it be dangerous to use cannabis in people with Parkinson's disease? So the next part of my talk, we look at actually evidence, so more structured studies that were done fusing cannabis or any derivative for Parkinson's disease. And so for that, I want to kind of step back and just give a quick introduction of how new treatments are developed, either in Parkinson's disease or other areas. So this is to say that there's different, it's a stage procedure or process of development. Initial studies looking mostly at safety, and then go on having studies, larger studies that try to confirm the efficacy of a compound. Most important, we see that there's a funnel effect. So both you see in the graph on the left, but also on the graph on the right, that, for example, for 10,000 compounds that, for example, by their structure, they thought they could interact with receptors that could be of benefit for humans, you see that renders to finally one compound that's approved by regulatory agencies. So in a way, we can speculate that it's a strenuous process, and the steps of validation, looking at safety and efficacy, they are very important because they help us to rule out medicines that are actually not efficacious for human use, and also that are not safe. And really, safety is a main concern with with any development of a new drug. And then is this to say that how we come up to do recommendations, so based in different levels of evidence. So not only the evidence that's brought by clinical studies, and we discussed a little bit that already, but also by the clinical judgment, and I'd say also very important, by patients' values and preferences. And the confluence of these three domains leads to evidence-based medicine. And really, what I've shown so far, we look at case reports or case series, which are really on the bottom of the pyramid in terms of the quality of the data. If we think about clinical trials, it's one step up in the pyramid, but then the best evidence is the one that tries to synthesize the results of multiple clinical trials, and that's in the form of systematic reviews and ultimately meta-analysis. But again, this is one piece of the puzzle. And really the heart of practicing medicine is try to synthesize these different domains of clinical judgment, patient values and preference, and the data that's brought by the studies. Okay, so I also would argue that we really need to build the evidence, but because it's not clear, I hope for anyone that cannabis it's equal to a parachute that we know we need to have to save our lives if we are being throwing out of a plane in high altitude. So really, it's not the same model. So really need to look at evidence to see where does the balance lie between a therapeutic benefit and safety and adverse events. So there's really not that many studies done of cannabis in Parkinson's disease, and actually my colleague and co-principal investigator of the study that I will present last, she has conducted clinical trials, Dr. Fox, on different compounds of cannabis in Parkinson's disease, and this is just a brief summary. So I would like to call your attention that the total number of people with Parkinson's role is quite small for 4 studies. There's many compounds used and tested in these studies, and they're quite variable. So they look at people with synthetic or studies that use synthetic formulations, those that just smoked cannabis sativa that can be readily available in a store or dispensary. So quite wide range, so huge variability in terms of what we're testing, although we might call it by the same umbrella term of cannabis. Then the studies, most of them actually were well designed as a randomized placebo-controlled double-blind study. And then also important, so whenever we develop a new therapy, we need to think about for what. And in these studies, they looked at dyskinesias that I mentioned before. The results were not consistently positive. And then also for the benefit of improvement of the Parkinsonism. So that means the slowness or the tremors, for example. Overall, and this is results from a consensus expert that reviewed the data available of cannabis. We look at studies that are small, and that's usually not good. We look at the crossover studies, so patients during the same trial will go have periods with the medication, other periods without the medication, and that's also not the best way to assess these new treatments, because there could be a bias for someone that, for example, didn't experience either, for example, a placebo and might have the idea that had a placebo and go on and having the active drug. So it can lead into things such as potentially unblinding. Typically, Parkinson's symptoms are chronic, so short treatment duration studies, they can have its place, but really when you want to confirm the effect of a drug, including cannabis, likely we look at longer studies. And then there's this aspect I think is very important. So in this list, you see many different generic names, but they have different compounds in it, different dosages, and so it's really difficult to know what actually are we testing, or at least how can we compare different studies if so different different formulations of cannabis are being used, and that's definitely a challenge. And so this has been synthesized by 2 major organizations in neurology in Parkinson's disease. So one is the Movement Disorder Society that perhaps many of you have heard. And in this society, which I'm a member and I take part in these initiatives of evidence-based medicine, we look at synthesizing all the data available, all the clinical trials available. And I will quote the statement on cannabis. So cannabis-based therapies are increasingly explored by patients for both motor and non-motor symptoms, with, to date, few randomized controlled trials fulfilling the EBM criteria for inclusion. So that basically means that there's few good quality studies conducted for cannabis-based therapies. And again, I think aligned with what I'm saying today, there's a clear need for high-quality studies to evaluate efficacy and, just as important, the safety in Parkinson's disease. This is also corroborated by the American Academy of Neurology. And these, they go on stating that probably marijuana is ineffective in treating levodopa-induced dyskinesias and tremor in Parkinson's disease. And again, this idea that we need to weigh carefully what are the risks and the benefits. And I will emphasize it's different, the individual experience of risk and benefits, and some of you might have that, versus what we try to collect as averages for a group, because otherwise it's very difficult to convey individual experiences to other patients, and how we go about teasing what really happened to that person in that one situation. And then they quote the risk of serious psychopathological effects was nearly 1%. So 1 out of 100 people could have severe psychiatric issues with in this case, medical marijuana. Okay, but I think again there's a huge interest, of course, the patient community, Parkinson's community, but I think also us physicians and researchers. And so this is a statistics I picked up from the clinicaltrials.gov, which is a registry, which any clinical trial that has been conducted in North America needs to be registered here. This is from last year, I have to say, but you see that there was like 7 studies being conducted in Parkinson's disease, 6 on this kind. The numbers will be larger. So what's the evidence of cannabis for pain specific? So we're kind of narrowing down and going to a specific indication. And so first, there's this systematic review, so the synthesis of different studies. They looked at improvement in pain with cannabinoids versus placebo in other conditions beyond Parkinson's disease. And overall, they conclude that yes, cannabinoids can have a role for pain. And these really, they seem to overall have an improvement in pain by using cannabinoids. Okay. Also, we know that Health Canada has approved cannabinoids used for neuropathic pain, the same Sativex that I mentioned before, both in circumstances of pain in cancer patients, but also in multiple sclerosis. If we go specifically towards Parkinson's disease, I was able to find a couple of studies, and both they were open label, and they didn't have any control. So they didn't enroll participants that would not have the cannabis, and so we cannot compare a group of people that went on having intervention versus a group of people that didn't have intervention. So this first study was smoked cannabis. They're looking at improvement in pain, and they document that, but they also document some side effects. So inability to smoke it, vomiting, dizziness, or psychosis. And again, that's a relatively small study of 28 patients. The second study, again, also small, so 20 Parkinson's disease patients. Again, open label. So all participants went on having the cannabis, either smoked or inhaled. In this study, I think emphasize what I illustrated before, that patients actually in this study did not receive a standardized formulation of cannabis. They gave different strains of cannabis from different crops, and it was not monitored pharmaceutically. They also report some benefit, but again, without any control, without any placebo control group. So what we're looking at is that there's questions to be addressed if you want to pursue the scientific evaluation of cannabis use in Parkinson's disease. So one, what's the type of cannabis that may help people with Parkinson's disease? So is it THC? Is it CBD? Is there a place for both? And what's the ratio that best provides an analgesic effect, but also in a safe way? And also, we need to have validated tools, both in terms of therapeutic benefit, but also of safety. And that not only depends on using the tools, right tools, but also being able to control the intervention group with the group that did not receive the intervention and had a placebo. Okay? And again, double-blind randomized controlled trials were not yet performed. And based on these, both Dr. Fox and myself took the initiative of proposing a study to Parkinsons Canada to try to really do a rigorous scientific evaluation of cannabis for pain in Parkinson's disease. And so we're looking at a randomized trial, looking at both tolerability and safety, and look at the doses. In this case, we chose a standardized formulation, which is cannabis oil preparation. In terms of safety, for the most part, but also trying to get some signals in terms of analgesic effect, again, for pain in Parkinson's disease. So the study is planned to be conducted both at Toronto Western Hospital and the Ottawa Hospital, so 2 centers. As typically these initial studies are, we're looking at a small study, so just 15 Parkinson's disease subjects, so people with Parkinson's disease with bothersome pain. In the study, we allow for patients to have cannabis oil once a day for a maximum period of 35 days. You're going to see, because safety and tolerability, it's our primary outcome, we allow patients to titrate their dose of cannabis oil once a day, taking once a day, and increase every 3 days 0.1 mLs, having the first dose in the clinic. And again, to really be very rigorous in terms of safety assessment. This is just another diagram explaining the trial, but I will emphasize so that we are looking at 3 different formulations. So we'll have 3 groups of 5 with 5 participants each, with different ratios of THC and CBD, looking at as I mentioned earlier on, the THC might be more problematic in terms of safety and tolerability, CBD less, but also looking at what's the best ratio of the 2 in terms of efficacy. Okay, and so this is roughly, as I mentioned, so it's 35 days, and patients actually, for this case, we decided not to use placebo because we are concerned about patients easily finding that they were either on the active intervention or on the placebo. But again, this is an initial study. Future studies, once we decide what's the best formulation and what's the maximum tolerated dose, we'll definitely will have a placebo control group. And hopefully we'll get that stage once we complete this initial study, again, funded by Parkinsons Canada. And so this study is going to be available both at Toronto Western and Ottawa Hospital. And who can take part? So definitely someone with diagnosis of Parkinson's disease, an adult, but that's really just a standard clinical trial criteria. They need to have bothersome pain, and we use a specific scale, so the King's Parkinson's Disease Pain Scale, that will allow us to see to use a criteria as a threshold for recruitment in this study, but also to monitor if the scores that patients have at baseline, so before having intervention, if there's any improvement or not. They should be on stable medications for the month prior to recruitment. Participants can use drugs to treat pain, but they need to be on unchanged dose so that we are sure that whatever we observe in the clinical trial in terms of pain control can be associated with the intervention we're testing. And subject cannot drive during the study, so that might be a significant limitation for some of you. Exclusion criteria. Really, the future participant in this study cannot be on use of cannabinoids or marijuana, because, again, safety is a concern. The presence of psychosis or a significant cognitive impairment will be exclusionary of this study, and other aspects that, again, could represent a significant safety hazards, such as impulse control behaviors, having, of course, a history of suicide in the last year or an attempted suicide in the 5 years prior, and then orthostatic hypotension can also be a concern, and then if they have significant medical issues such as related with the kidney disease, liver disease, or heart disease, then usually people that have these conditions that are medical unstable, usually they don't take part in clinical trials. And again, it's just because we're testing a experimental therapy, and we want to minimize any potential risk to these people. And then because there's the potential for abuse, anyone that has a history of substance abuse, substance use disorder, whether alcohol, prescription drugs, or even illicit drugs, will be also exclusionary of taking this part in this study. Some of you might be thinking, and I think I saw already some questions about how can we take part in this study. So at this point, the study is not enrolling, I have to say. Currently, we do have approval by the ethical review boards in both hospitals, but we did come to barriers in terms of the change in the regulatory scenario of the use of cannabis. And actually, since it became legal, it became more complex to actually start trials on cannabis. And so actually, we just wrote recently an appeal to the Ministry of Health and Long-Term Care, and also Health Canada, to try to expedite this type of trials. So hopefully, we hope to be able to recruit and to announce that we are open for recruitment sometime during this year. Of course, also the current situation with the public health crisis of the COVID-19 has put an hold on almost all recruitment for clinical trials, at least in Ontario. And so that might delay things. But again, we are not yet recruiting. So if you are potential candidates and are interested, feel free to reach out for us. And we can always put you on a pre-screening list and consider your wishes of taking part in the trial in the future, hopefully this year. And finally, as I think take-home messages that I hope I was able to convey today. So point number one, unfortunately and currently, there's no high-quality evidence to support the use of cannabis in Parkinson's disease. But we know that people with Parkinson's disease taking cannabis is a reality. We're in a situation where perhaps there's many beliefs, but there's little evidence. And so how can we increase evidence and, in a way, feeding well-structured and well-reasoned beliefs? I think is by doing clinical trials to assess the risk and efficacy in Parkinson's disease. But we need to do it for specific indications, either tremor, pain, and for a specific intervention, so that ultimately we're able to conclude that the specific intervention is beneficial for patients with Parkinson's disease, not putting at risk their safety. And so that's ultimately what we aim, both me and Dr. Fox. And with this, I'll finish my presentation. I'd like to thank your time for listening. And I think now we are open for a period of questions. I'll ask Stan to help me. How should I manage the different questions I'm seeing in the chat?
Yes, I'll take care of that, Dr. Mestre. Thank you very much for an enlightening presentation on this really important topic and very trending topic as well. So, yes, if anybody does have additional questions, please feel free to enter them into the chat. We do have some questions that have been entered already, and I'll just start with some of those. Are there any other known negative interactions other than psychosis for taking cannabis during or while I have Parkinson's disease?
I can go back, Stan. Oh, let me see here. Do I have it here? No, sorry. I mean, I think it's definitely the most concerning is I would say, I mean, psychosis, but also other aspects of a psychotropic effect in the brain. So not only could be confusion, psychosis, hallucinations, drowsiness, reduction of mental acuity, and these are really side effects. And so those are definitely the ones that are more concerning to us also as physicians. And as you might have the experience with other drugs,
there's a long list of side effects that you can easily find in the product monograph. But really, these ones are, I think these ones are more concerning to us because we're looking at the people with Parkinson's disease usually are at a more advanced age group, and most of the data that we have, even the scattered data I presented today in terms of safety of use of medical cannabis, usually does not refer to these age groups, so actually it's younger people. So again, a reason to be concerned and to be judicious in terms of how we go to develop and to endorse the therapeutic use of these compounds.
Okay, great. Thank you very much for that. Another question is, I am taking a synthetic opioid for chronic back pain. Mm-hmm. How do I go about trying cannabis for this pain? Can I do them at the same time? Do I have to stop one? Do you have any comments on that?
Okay. Again, I would just respond in general terms. And so first, I don't think it's difficult to say that there's evidence saying that it's safe to use cannabis when someone is on opioids. I think it needs to be a delicate decision. Typically, and again, in very general terms, whenever there's, two drugs that can have an action in the brain, there's a higher potential that they can interact in an unfavorable way. Although, again, the main goal is to reduce pain, I think it can be unpredictable of how can they jive together. And so I could not endorse it, and even not knowing your particular case, which I would not like on this stage. But just in terms, I think you should go back to your GP or even a pain doctor and ask this question. But it's definitely a delicate decision.
Okay, thank you for that. Another question is, have there been any studies on CBD and sleep issues for people with PD that you know of?
Again, aside from the surveys I mentioned to you, I'm not aware of specific clinical trial, and because we're talking about treatment development that was done specifically for addressing the issues of sleep. Although, again, in general, in reviewing what we could expect from the action of these compounds in the brain, yes, they can be in a way sedative. They can, for example, they can be anxiolytic. So these things can contribute for insomnia. So again, there's potential rationale, but needs to be explored and needs to be tested.
Okay, thank you. A little bit of a different question here is, this listener has heard that terpenes in cannabis plants are more effective. Do you have any comments on this?
Can you repeat? I just heard plants.
Terpenes in cannabis plants are very effective, and they just want to know if you have any comments on that.
Yeah, again, I would return to my mantra that I cannot say yes or no because I'm not aware of studies, clinical studies, formal studies done, either comparing the plants with another cannabinoid, either synthetic or a more standardized formulation as the cannabis oil, or that those plants and a placebo. So I will not have the knowledge to confirm that they are more effective, but I will be willing to examine the evidence if that exists.
Okay, good. This is a more general question. You had mentioned that people could participate in the screening process for clinical trials. How do you get into this trial, or how do you get into the pilot project? Should we contact Dr. Fox, or is there a listing somewhere that we should address?
Yeah, so depending I would say you should contact, if you're interested, either my center in Ottawa or in Toronto, depending on where you're currently living. And typically what happens, we'll if you're not a patient already seen at that center, it requires for you to be referred to that center, so at least to be evaluated clinically. And then, as with any other trial,
as long as we are active in terms of recruitment, and we'll have to inform you about the trial, which is a more formal process than what I just did today, more detailed, and then which is the informed consent process. If you're willing to take part in the study, then you enroll in the study. And so it could be, but just at this point only at Toronto Western Hospital or Ottawa Hospital, and we'll welcome not only the patients we really follow, but anyone that's interested. So you just need to contact us, and likely we'll request also a referral letter if you're not followed at the center currently.
Okay, great. That's great information. This person asks, are there any advantages to synthetic cannabis extracts versus natural?
Yeah, so I think the most important is that we know what's in the compound, and so I would say it could be either natural or synthetic, but as long as you have a good notion of what basically you administering or you're taking, and I'm saying that like even in the clinical research level, because as I try to illustrate, someone can say that smoking marijuana leaves it's helpful, but then the question remains of what has helped that person within that mixture of compounds. Remember that my first slide mentioned that there was perhaps more than 100 psychoactive compounds or pharmacological active compounds in the plant, the Cannabis sativa. So in that way, it becomes more difficult to say what's beneficial, and also as the other side of the coin, what's potentially dangerous in that administration versus something that it's isolated, purified, either naturally or built synthetically in the lab. So I think it's most important that we know exactly, explicitly, what are we studying in clinical research, and ultimately what the patient will be taking.
Okay, thank you. This is sort of a follow-up on getting in touch regarding the trials themselves. Yeah. This individual is asking, why do all of the studies have such a small number of participants?
Yeah, so I think it varies with the stage of development. But I would have to agree, yes, that thinking about a patient perspective where you access a trial in a center, so typically each individual center will contribute for a study with a relatively limited amount of participants. So there could be 5, 10. I would say that perhaps somewhere in between, that's the average. And so in that sense, for someone with Parkinson's disease that is seen at the center that runs a clinical trial, it always looks very small study. But overall, the studies can be quite large. So a clinical trial can recruit 300 patients, 600 patients. Of course, this doesn't apply to this current trial because it's almost the first trial done in patients with Parkinson's disease, especially with this cannabis oil. And so typically those are small, even overall for the entire study, because again, we're looking at obvious signs of toxicity that will preclude us, for example, from advancing for larger studies where they are able to do a more fine analysis and capture both better signs of efficacy, but also less severe side effects. So they would capture also the major side effects, but also perhaps less frequent and milder side effects. So that's why we go from small to larger studies, although at the center level, as I said, on average, maximum, we will look at between 5 and 10 participants from a given center that are recruited for a specific trial. So ultimately, I understand in a way of frustration, because if there's a huge interest for a clinical trial, there's this kind of funnel effect at the center level. But I hope I clarified why.
Okay, thank you. A little bit related to this too is, how can we add our voice to express concern regarding the need for more studies or the delays with approvals? Is there somewhere that we should contact? How do we voice that?
I mean, I think Parkinson's Canada it's a wonderful vehicle to do that, and then through the institutional context, Parkinson's Canada, that's I think a wonderful way to do it. I mean, contacting, but again, it could be grassroots movements. You know, you contact your local MP representative if you think it's worthwhile. At this point, to be honest, I would not know if Health Canada has a public line where you can convey those sentiments and ask questions. But I think all these options and others are possible. But I would see Parkinson's Canada as a privileged partner to advocate for more research. I would say in Parkinson's in general, but I mean, attending to the recent society change in terms of how we see cannabis in Canada. I think also other potential strategies can be explored and should be, but I will leave that to each one of you.
Okay. A general question here is this person heard in the presentation about titration of cannabis oil. What is titration of cannabis oil?
Okay. Sorry. So I'll clarify. So titration basically means we slowly increase the dose, and again, as an effort to really be careful and rigorous about safety. So by increasing slowly, we're able to record any changes in terms of, for example, occurring side effects of adverse events that, for example, occurred after an increase in the dose. And so it's kind of this stepwise increase of a dose in time, and then we can monitor the outcomes of each increase. And ultimately, we find what could be the maximum tolerated dose for each participant. So it just really means that we don't start right away with what we would call a target dose. And for the ones that have started the medication for Parkinson's disease, likely that was the experience, for example, with any drug, but typically and classically with levodopa, likely you start on a very small dose, not doing 3 times a day, and slowly you increase that dose to a given level, and in which you stayed for chronically.
Okay. This is a bit of an advice question, even though we don't take or solicit medical advice here. But I can appreciate that many people are maybe in this situation. Mm-hmm. This individual is asking that they'd like to try cannabis, and they want to know what to look out for, or for their caregiver, what should they look out for if there are negative effects, because they themselves may not know. So they'd like to start trying it, but they don't know what to tell their caregiver that they'll be on the watch for.
Again, I think so. We mentioned perhaps the most concerning side effects today, but again, because there's such a level of uncertainty, I would say that your caregiver, for example, and even yourself, for example, if you don't develop confusion or psychosis, definitely anything that happens by definition once you start a treatment could be potentially related to that treatment. Okay. And so even ourselves in clinical practice sometimes are surprised by a report of a side effect by a patient that was not within our radar of the most frequent side effects, and we have to assume that potentially is related to that medication or drug, and usually what we'll do is either reduce the dose or even stop that medication and see if the side effect goes away. So I would recommend the same, the same approach, and I think even more because there's so much uncertainty about what these type of interventions can cause in humans.
All right. Okay, and we're just down to 3 or 4 minutes left. I'm just going to ask one last question. It's a little bit detailed, and I guess we'll see where we can take it. In 2016, at the World PD Congress in Portland, the University of Colorado professor said that people with Parkinson's should stay away from THC since it plays with anxiety levels. This person's question is, why is the 18-0 formulation being used in the upcoming study?
Yeah, so that's a very important question, and I think it leads to the. So again, I will have to be in the World Parkinson's Congress and see what was said exactly and what was the justification for that statement. But I think today, I think I have some insight to it, because as I started by explaining today, the THC likely has more psychotropic effects. But again, therapies are developed by evidence, and you might consider that's a little bit uncanny on our part to test something that has only THC. But I think we need to generate that evidence in patients with Parkinson's disease. But also perhaps addressing a concern you might have, like, why are we doing that? So first is to gather the evidence, but also I think we're being very careful with this. So the first administration will be in clinic, and will be on the smallest dose. So not only the participants of this study are going to be rigorously monitored, either to in-person visits in the clinic, phone calls. The first administration is going to be in the clinic, and also we'll use that concept that I explained earlier about the titration, so that we can really monitor if with THC only is any difference by the combined formulation of THC CBD or a virtually exclusive CBD formulation. But we have that same concern, to be honest. But I think because of the lack of these studies formally done in Parkinson's disease, we just the way science is done and clinical development of drugs is done, we need to generate the evidence, and of course taking the safety precaution that I just explained, so that we don't put patients into an unnecessary risk or severe side effects.
All right. Thank you very much for that answer. So that is the end of our question period. I just wanted to say thank you, Dr. Mestre, for an excellent presentation and discussion. And I'd also like to thank everyone for attending today's session. We would like to remind you that our next webinar is coming this Monday, April 27th at 1 p.m. Eastern Standard Time, and it will be on cognitive behavioral therapy with Andrea Khalid. In conclusion, on behalf of Parkinsons Canada, we wish you all an enjoyable afternoon. Bye for now.